Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast. Today, I am joined once again by Giles and Luke. Welcome to the podcast.
How's it going?
Good, right. Good to be back.
Today, we are going to be discussing how to integrate manual therapy with exercise. And the main issue I see with this, especially on social media, is that people create this false dichotomy between the two. It's one or the other. I know last week we were talking about these kind of outlandish techniques in terms of manual therapy. We were discussing the Y strap and the fact that social media kind of perpetuates this, right? It gets clicks. And this is another instance with social media that I've seen where people kind of, they want to zone in on one thing or another to create this false dichotomy and get clicks and likes and all these things, when in reality, we don't need to separate out the two. If you're passionate about manual therapy, that's great. Make sure you've got some type of off-ramp or pipeline into exercise rehab. If you're passionate about exercise rehab, you can either have somebody that you refer to or work with, or you can integrate SAMT, which I talked about last week, which is self-administered manual therapy, which in itself comes under the banner of exercise itself, right? And that's something I want to talk about. Before we get into really discussing the nuts and bolts, just so happen to have an expert on manual therapy on the podcast. So, Giles, 6 books in, internationally published researcher. You published a phenomenal piece of work in 2018 on the effects of spinal manipulation. Is that correct?
2019.
2019. It was around,
I think
so
it's
around
2018, 2019.
Yeah. And I obviously have done something similar from a chiropractic perspective. Our work together is fairly comprehensive on the effects of manual therapy. So do you want to take us through a little bit about what the hell is happening on a neurophysiological level when you are using these interventions that are manual therapy?
I think let's keep it simple. It's like the KISS mnemonic, isn't it? Keep it simple, stupid. I look at manual therapy in a simple way. It's using a varying different interventions, whether that's mobilization, manipulation, massage, needling, acupuncture, whatever technique or whatever modality you're using that to try to create symptomatic modification. I'm going to try to help to change that patient's presenting symptoms, ideally to reduce discomfort and pain or potentially reduce muscular tone. I'm also going to use that intervention to try to help to temporarily improve function or mobility of an area. I'm trying to use a technique to create a temporary neurophysiological change. That is either a symptomatic modification where we're trying to make the patient feel better, either through reducing pain or potentially reducing muscular tone, or I'm trying to help the patient move better, and I'm going to help them to create temporary improvement in function. So we use a variety of different techniques to help them feel better and move better for a short period of time. But what manual therapy is not doing is it's not fixing anything. So as a manual therapist, I can't fix your osteoarthritis. I can't fix your disc prolapse or your bulge or any of that. But what I can do is use a plethora of techniques to temporarily create symptomatic and functional modification for a short period of time to allow the patient to create tissue resilience through exercise rehab. That is how I look at it from a simple format.
People will argue that on both sides of the camp, passive interventions, manual therapy is a short-term intervention. Some will argue and say, no, it's a long-term. Is there ever a time or a situation where manual therapy can be a long-term intervention? If so, when? To
be fair, I don't think so. I actually think what the patient does off the table is more important than what we do on it. And if the therapist is purely using passive intervention, such as manual therapy, I actually see that as quite low value, because I look at treatment as either high or low value. If all I do is rub it and nothing else, I think that is a low value intervention. You're going to feel a bit better for a short period of time, but ultimately we're going to keep coming back to the same position. If all you do is chuck exercises at someone, but without potentially creating that symptomatic or functional modification at the start, with education, with understanding, then I also think that could be seen as quite low value. I think that's when you bring the two together, you then get high value. So from my perspective, I would not want to have a patient relying solely on manual therapy for the whole duration of their treatment process. I think that is quite misguided. And I don't think you're going to get the results that you are hoping for. You're just going to get reliance. You're going to get a good paycheck, but then you come up with an ethical consideration there of what's beneficial for the patient or what's beneficial for your pocket.
Yeah, what do you think, Luke?
Yeah, I agree. It's definitely dependent as well, right? In person within clinic versus someone like yourself who's been doing a little bit longer online as well, treating clients. I've had patients come from both ends of the spectrum. They come from clinics that's purely passive treatment, hands-on, no exercise based, where, like Giles said, it's very short term. They don't get much change for that long. But then I've also had patients come from, let's say physios, for example, that all they've done is throw a bunch of exercises at them that hasn't helped either. Now, that may be a case from purely misunderstanding, poor education around why they're doing these certain exercises, potentially just practitioner bias, like, I like these 5 exercises. I think they're the best. Let's just throw them at you. I think you've got to meet somewhere in the middle for sure.
Well, it's that therapeutic alliance, isn't it, between utilizing manual therapy and utilizing exercise therapy. And just because a technique has worked for someone doesn't mean it's going to work for everyone. This is the individualization, and it's a bit of a slippery slope. The therapist gets a couple of results with one thing, they just chuck that one thing at everybody and just hope on sort of anecdotal evidence that it will work. It's a little closed-minded. It's a challenge, very big challenge.
Especially too, I've had patients come from, they'll prevent with some sort of, let's just say, lumbar facet irritation, and they've been given extension exercises from a previous clinician. Well, of course, that's going to aggravate things and piss it off a lot more. So that's where I may use something initially that's a bit more short term to modulate their pain. Initially, they're already coming in with sort of like that low self-esteem, pretty unaware as to, what's going to happen next. So
you're now using manual therapy to help to reduce fear of movement. Basically, so basically you can utilize manual therapy to basically put the patient into a positive mind frame that they can do these movement patterns. They're not going to injure themselves. We're avoiding this catastrophic thought process, and it can actually be a positive enhancement to the rehab process, because if they're fearful that they're going to be in pain, they're not going to want to do the exercise. Yep. And then you're in this catch-22.
You can change some of that after the first session, then already they're willing to trust you a lot more and things. Yeah. And adhere to what you have to say. So
both of you brought up a good point about how certain exercises can be used and they may not work, even if it's exercise interventions. And here's the thing: exercise as an intervention or as a systemic approach or as a general health approach are all very different things. And the banner of exercise is so wide that when it comes to the research, we have a real issue quantifying what it is, when it is, how it is, especially when you put it up against manual therapy. And so the problem is we see these clickbait titles on social media that will say manual therapy is better than exercise. It will say exercise is better than manual therapy. And you'll get these kind of false dichotomies. But when you look into the actual research design is flawed. And not every practitioner has the understanding or the education to know how to pick apart a research design, and they're going to read the title of the abstract. So if you're listening to this podcast, please come on this journey with us and remain open to the information that we're putting out there. If you're all the way on the side of exercise or if you're all the way on the side of manual therapy, we're going to talk about how we can integrate these two things. First step, be wary of research. Why? It's very difficult to compare exercise and manual therapy. You have to take exercise, you have to dumb it down so that you can quantify one part of it. Right? So you can compare one part of it. What type of exercise? How is it being performed? All these things change it. When we look at exercise, we have it as a specific intervention. We have it as what could mimic manual therapy with SAMT. And then we have general exercise. If we were to put manual therapy against exercise as a general overall health outcome, it would not stand a chance. It would get blown out the window because we all understand the benefits of general exercise for humans, right? A reduction in all-cause mortality, an increase in VO2, reduction in adipose tissue, an increase in bone density and muscle mass, increase in cognitive ability or brain function, increase in metabolic pathways, hormonal pathways, reduction in heart disease, blood pressure, various types of other diseases. It's been shown to modulate and change anxiety, depression, stress. It is so wide. that if you were to compare that to what exercise can do in a general sense, you can't do it. So then when we do research, we dumb it down, we single out one thing, and we say, okay, cervical manipulations versus isometric hold, manipulating a shoulder versus overhead band work. We're taking one thing out and we're comparing them. We're taking two horses, like two star horses, and making them race when it's not an accurate way to look at this situation. What is an accurate way to look at the situation? And here's the thing. Manual therapy is a catalyst for exercise rehab. Manual therapy is a phase potentiator for exercise rehab. We use phase potentiation in sports science. We use one phase to bring out the potential of another. And we build so that by the time you get to competition, you're the best you've been that cycle. Manual therapy shouldn't be taken out of the picture. Exercise certainly shouldn't be taken out of the picture. They can be used together, integrated to get the best for the patient. It can be a catalyst for faster return to movement. So we're modulating pain through manual therapy, which is bringing the patient back to movement faster from injury. And you guys even touched on that in terms of fear avoidance of movement. It is a catalyst for better movement by improving range of motion, which is fairly well documented with manual therapy. It is a catalyst for more efficient movement by improving motor control, which is again established by the research in terms of increased balance with proprioception, etc. It's a catalyst for improved movement performance. You can apply, we talk about PAPE, post-activation performance enhancer. You can do that with manual therapy too, because now we're looking at what would be, say, a PNF or an MET. We're having a neurophysiological adaptation or change. We can use that to elicit neuromuscular mechanisms and proprioception improvements from manual therapy. It can be a catalyst for movement confidence by removing muscle guarding and encouraging tissue motion prior to actually getting the person to exercise, which we touched on before. And it can be a catalyst for loading movement by removing all of the rehab barriers that I just mentioned. That is how we need to be looking at this equation, not creating false dichotomy between the two things, not trying to get clicks and start an Instagram war, which is just what I see often and I get tired of it. So Giles, tell me, when it comes to in clinic, when it comes to working with patients, they come down, they lie on the table. You are out there as a osteopath. That's the name on the door. That's the name on the shirt. They're expecting hands-on. How do you educate? How do you discuss? How do you communicate the importance of having an off-ramp from your manual therapy into what would be some type of exercise?
It's very challenging, especially when you have patient non-compliance being so dramatically high. I mean, something, was it the statistic like 80% non-compliance in physiotherapy with exercise prescription? So 80% of the time you give the patient something to do and they're not going to do it. It's incredibly challenging. And then on the flip side, you have someone who's incredibly sports specific, incredibly focused, and they want to do way too much. The key emphasis for me is about patients. It's about almost the SMART objective. Things have to be simple, measurable. They have to be achievable, realistic. You have to have this time frame around it, and you have to individualize what you're going to do with your patients. That can be something as simple as education and explaining to the patient the benefit that they will get in the long term from integrating things like just walking, general health exercise, lifestyle changes, sleep. And then once they start to add that into their daily routine, then you can start adding and adding and adding. The problem is when you add too much at the start, they're going to do none of it. So it's very difficult. So I'm very honest with my patients. I'm very honest. I'm also very expensive, right? If you want to come to see me and just want to lie on the treatment table and have me rub and crack you and get a couple of days relief, maybe a week, maybe two, I'll take your money, but I'll be honest with you and say this is not going to fix your problem. If you want to just come in and keep paying me, I'll keep taking your money. But if you want to actually deal with your condition, you have to actually do some work. And that is where teamwork between you and the patient is crucial. The shared decision making, this understanding of what it is, why it is, and then how you're going to then achieve it. And it might be something as simple as starting them off with a 20-minute walk once a day. It then might be something as simple as then adding in some basic exercises. Because the reality is treatment is expensive, right? You come and see a therapist once a week, twice a week, it is expensive. Exercise, you can do it at home. You can do it for free. You can do life-changing things for $0, right? You can change your life for $0 by integrating 20 minutes a day of basic exercise. So for me, a lot of it is about being open, honest with my patients and saying to them, listen, if you just want to keep giving me your cash, I will keep taking it. But if you actually want to deal with your situation, you are going to have to suck it up, buttercup, and we're going to have to do some work. And remember, as the therapist, you are the coach. I look at the therapeutic relationship as I'm the coach. The patient is the star. I want that patient to be smashing that freaking gold medal, and I'm going to help them to get there. And we're going to have to do it through graded exposure to different stimulus, different training styles, and also finding what they enjoy. Because if they don't enjoy it, they're not going to do it. And this is where communication comes in. But unfortunately, a lot of therapists, and I talk from an osteopathic perspective, my 5-year degree, we did practically zero exercise. It was a poor. I mean, I come from an exercise background, but when people are doing a 5-year degree and they're going out into the real world and they don't have that integrated knowledge, they're on a sticky wicket. And I always say to new grads, the best thing you can do is go and team yourself up with a great S&C coach, a great personal trainer. Go and spend money on exercise courses, because I kid you not, it will change the way you treat your patients and you'll get crazy long-term benefit.
The way Giles is practicing and educating his patients is unfortunately a very low percentile of clinicians out there. So 8 to 9 times out of 10, these patients are going to clinics and they're being told that this passive treatment is the cure. It's what they need to fix their injury. So when they finally come to see someone like us or Giles and we say something completely different and actually educate them around this, they're quite shocked initially. I know for me, it's definitely dependent on the type of person you're dealing with. So I've figured out sort of different techniques and methods to deal with something like that. So a lot of the time for people, for example, if it is a tendon-based issue, I'm going to show them an isometric early on, because I know majority of the time it's going to respond within that 5 to 10 minute time frame I'm demonstrating it. I'll retest the issue that I did before, and a lot of the time it is better. So initially that compliance with the patient demonstrating the exercise, they're going to be more likely to do it as well. So yeah, it just comes down to patient education for sure, and utilizing those different techniques for different personalities as well.
Yeah, the interesting thing between these two things, right, manual therapy and exercise, is the gray area, the gray zone. There is a gray zone between the two things where it is hard to differentiate which is which. If someone's on the table and you're taking them through some stretching, I mean, dynamic stretching, static stretching, whatever, it is what it is. But like PNFs or METs, I mean, we're having these neurophysiological responses and we're mediating tissue length through obviously the nervous system. It's a very active passive modality. You can very easily put yourself through a PNF stretch or put yourself through an MAT, or you can put yourself through various types of manual therapy. Like I've talked about, I will use manual therapy, but I will teach it, educate the patient, and I'll get them to a point where they can perform it at a level that I would deem quality enough that they're going to get the outcome that they desire. It does become a gray zone. If somebody is having an issue with mobility, you could take them through a manual therapy. You could do some tissue gliding, some IASTM, mobilization, manipulation, dry needling. You could do all of these things. You could also get the person to do self-mobilization. In some cases, people can even do self-manipulation. That's not something I would advise, but it happens. But in terms of mobilizing, you can mobilize various parts of the body very well, especially if you're going to improve like a distraction, like a band, like a posterior glide with a band. Now you're opening up a joint in the direction that you want. Now you've almost got like a mulligan movement type thing happening. So like there's various ways to look at it. Let's get to a point where we can be a little bit more mature as practitioners and therapists and say, we're open to integrating. If you're lacking on one thing, go get better at that. And like Giles says, he sees students that are coming through these institutions, they may be able to do a killer cervical adjustment or thoracic adjustment, but then there's nothing in the curriculum that is really educating them when it comes to exercise rehab. And that is going to be a problem. If you just want to do manual therapy, find somebody you can refer to, but you still need to understand it enough that you can know the end goal, that you can know where you're heading. For example, and I think we may have put this in the book, Giles, but if someone's coming to you and they've got an active lower limb injury, you've got yourself what would be a medical diagnosis. So that could be anything, right? The medical diagnosis could be anything to do with the lower limb. But then you uncover a functional deficit. So you're working with a functional diagnosis now. If this person, you got them to squat, they can't squat, they've got a restriction in their ankle. You decide, okay, I'm going to do some manual therapy. So you do some mobilization, or you do a talus manipulation or calcaneus or whatever, right? You get that moving better, then you retest, you get them back in the squat and they're moving better. That's a short-term window that you're going to have. But you could also send them on their way with things that they can do in their own time. So they don't have to keep coming back to you. So you're just cracking their ankle. How do we mobilize this joint? How do we put this joint into a position where it's going to help me when I squat, when I deadlift, when I'm bending down to pick up my kid, when I'm getting up and down off the toilet? This is a massive thing we deal with when it comes to lower back, because you have to actually find provocative movements and you have to give people strategies to move in a way that's not going to hurt and continue to aggravate what's happening in their back. Otherwise, they're never going to get anywhere. You can crack them, you can rub them, you can whack them, you can give them exercise rehab till the cows come home and nothing's going to change, because they are aggravating the tissues time and time again, because as a practitioner, you've failed to identify the parts of their day that are flaring them up. So that's another thing to consider. And that's also something that could potentially come under exercise rehab. So it is a very large topic.
Do you know what I would say? I think one of the big mistakes I see manual therapists doing, especially if they're not integrating good aspects of exercise rehab, is they're quite short-sighted. So they are looking at that person in that moment, they're trying to desensitize, they're trying to improve function, but then there's no then what. So I keep saying to the students, fine, you've cracked their neck, then what? What is the strategy that you are then going to put into place to create long-term change? And that has to be through exercise rehab, lifestyle changes, education. I have no problems in the therapist utilizing exercise rehab within the clinical process. I've got no issues with the therapist giving patients self-mobilizations to do, self-exercises to do. I have no issues with that. I have an issue with patients self-medicating and buying pharmacology off the internet to treat their pain, which I see as being hugely more dangerous than someone self-mobilizing their thoracics, lumbars, knees, or hips. So for me, a good therapist is able to educate the patient, give them coping strategies and mechanisms, and lead the patient into a healthier lifestyle through exercise rehab. And if we're not doing that, then I really do think that we are no better than an ibuprofen. If all you do is rub the person and nothing else, you are just an expensive ibuprofen. It's the combination between the two, in my opinion, is where you get long-term lasting changes. Otherwise, you are just creating low-value, repetitive intervention.
One thing briefly, just touching on sort of patient compliance and expectation. I know we've talked about it a lot, Brogan, but it's end of the day, it's definitely the profession that's failed a lot of these expectation and compliance with the patients. Like time and time again, if you're seeing clinics that are marketing certain passive treatments, they're putting soft tissue videos, they're putting dry needling, they're putting do these best three exercises to fix your back pain all over TikTok and social media. Like, how do you expect the patient to walk through the doors and, listen to what you have to say when you're putting up, one intervention for a specific region of the body part, trying to demonstrate that this is the one sort of modality required? It's just a double-edged sword, really, at the end of the day. So I think it does come down to, when you are looking to open a clinic or you're looking to do things online, set clear boundaries. Don't shortcut and cookie cutter every approach to different issues, if that makes sense.
Yeah, we have talked about it, and you're absolutely right. It comes down to the clinic and how they're putting themselves out there. If you're putting yourself out there and constantly promoting, and all your PR and all your social media is around the crack and the click, and you've got people putting little microphones on the patient. I mean, we've talked about this before. Where is your focus at? If you're saying to a patient mid-treatment, can I please put a microphone on you so I can crack you like a glow stick so it sounds better? Like, at that point, just put it in post. Like, stop being lazy. Just download
the problem,
iMovie.
I was going to say that treatment, that's not patient-centered, that's self-centered. That is a treatment about the therapist, not about the patient. And that is fundamentally what's wrong with social media and clickbait. It's this sensationalism. And we talk about it a lot, but there's a problem with young therapists believing that the number of followers they have relates to the skill that they have. And the reality is the number of followers you have on social media is purely a vanity metric. It is irrelevant in the big scheme of things. And it's a very slippery slope to go down. It's almost, there's a concept, I think it's the halo effect, where people have this almost guru status, and the louder they shout, the more followers they have. It must mean that they're true. But the reality is treatment is complex. Exercise is complex. One thing does not fit all. There is no such thing as 6-minute abs. Do you know what I mean? I wish there was. There's 5-minute abs, 7-minute abs. That is how I see a lot of these posts that you're describing, Luke, as sort of snake oil 6-minute ab adverts that you see at 2 a.m. on a TV shopping channel. And it's misinformation. And as we all know, exercise takes time. It takes complexity. It takes individuality. And it also takes someone who knows what they're doing. You can't just, give the same 3 exercises to everybody, because if that was as simple as it was, we'd all be doing the same thing. And that's unfortunately just not how it works.
At the end of the day, I think everybody can agree on the fact that when it comes to rehabilitation, every patient's going to walk in, they're going to be different. They're going to have their own provocative factors. They're going to have their own movements that they can and cannot do. And so we should just be a little more patient focused and a little less getting revved up from social media. As you said, the metrics of social media, what is it really showing? And I'll say this to you now. I have some fantastic friends that are the best in the world. And the ones that are really in the thick of it, working with the best athletes, working with the VIPs, working with the sports teams.
No one knows them.
They're too busy doing the work to be worrying about posting every day, because what's going to give you the best outcome on social media? Posting 3-4 times a day, being fully in, absolutely, that's your one focus. You're engulfed in everything with social media. If you're watching somebody and they have a high social media account, they're clearly good at social media. Does that mean they're a good clinician or a good practitioner? No, it doesn't. I'm not saying that it's everybody. It's not a blanket statement. I'm just saying be wary. And the biggest problem I have here is when people kind of get upset or they kind of get down on themselves because of what they see on social media. You say this to me all the time, Giles. It is not what things are not what they seem. People put out on social media only what they want to put out so that they're seen a certain way. And half the time, if not more, if not 90% of the time, it's bullshit. Most of the time, people are putting something out there that they just want you to see because they're trying to sell something. We're here right now because we're trying to educate and communicate and do the best we can. Because I often say this to Luke, I don't want to turn around as soon as I get a little bit of success and pull the ladder up behind me. So many people I know have done that. They go through these hard yards. They go through a curriculum that's broken. They come out of a industry or a profession that's broken, like me and Luke have. They get a little bit of success doing their own thing. Maybe they get a little bit of success cracking necks and doing the flying 7 and cashing checks. Then they turn around and they pull up the ladder. They don't want to help anyone else. And so the whole point of this Blueprint podcast, as we've said before, is to actually give people a play-by-play. Hopefully by the end of these 30 minutes, you feel a little more confident and you feel a little bit more like grounded. Like, okay, these 3 dudes are trying to talk to us.
We're all with you. We're all with you.
We're trying to be honest. We're not here trying to sell anything.
I heard a great quote about social media. Being famous on social media is like being rich in Monopoly. Do you know what I mean? I thought that was just perfect. Like, I don't know how many years we've got collectively of education and of a clinical practice, but I just seem to be becoming more and more disillusioned the more I see social media, the more I see what's happening to young graduates. I feel disillusioned for them because they're so confused. They're so conflicted by what they're being taught at university, what they're seeing on social media. And when they're not getting these amazing results, when they're not getting the results that they're seeing online, they just feel disillusioned and unhappy, and they feel lost. And I speak to students all the time, and the repetitive thing they say to me is they feel lost. They're not sure where to go, who to follow, who to listen to. And sometimes listening to the person who shouts the loudest is going to lead you down the wrong path. It's a challenging landscape to navigate in 2025. I feel very sorry for new graduates. It's very challenging for them.
Absolutely, it is. Well, thanks for listening. That's into the
Yeah.
podcast. We try to keep it fast. We try to keep it to a point where people can digest the information because there's just so much we can and should talk about. But there's going to be more episodes. If you're enjoying the content, be sure to follow the Rehab Professionals and OMT Training on all social media platforms that you can find. Especially check out YouTube because these clips and the long form are going to be on YouTube. And the podcast is on like every podcast platform possible. So I just like put it up everywhere, like iHeart, Spotify, Apple, Google, YouTube. You can listen to it to wherever you get your podcast from. And if you like it, jump on our social media. Be sure to like and comment and engage in conversation if you want. We welcome it. We absolutely, just as long as people are polite, we welcome discussion. If you want to disagree, that's fine. We also welcome that because at the end of the day, that's how we get better and that's how we learn. And what we are sitting here, us three are sitting here after the experience that we do have in various things, still willing to learn. And if we're sitting here saying that we're not interested, or we can't move past our own bias, or we can't learn something new, then that's a major problem. And if someone is saying that, I would turn around and not follow them. Anyway, thanks for being here.
Have a great week. Thank
No,
you.
good man.
Yeah, have a great week. All right, see you later. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast.